Bismillahirrahmanirrahim. My name is Aziz. I am final year medical student. My colleague Dr. Zulfaqar in Bangash. So let's start the presentation. Respiratory examination introduction. Introduce yourself by full name and role with the healthcare team. Check the identity of the patient. Explain examination to the patient. Gain informed consent for the examination. Wash your hand and using the IELTS technique.
Bismillahirrahmanirrahim. Assalamualaikum. Today I am here to present a case of a respiratory system. So I will check my patient, and first of all I have to sterilize my hand. So I have to sterilize my hand, and then after sterilization, first I have to introduce myself with my patient and ask the patient identity. Age 24.
General inspection. General inspection. Breathlessness, sweating, pain or discomfort, color, cyanosis, pallor, and other sign to note. Stride, wheeze, harshness. Can they talk in the full sentence?
In the respiratory system, first I have to ask the general symptom of respiration from my patient. Okay? Do you have any chest pain? No. Pain? No. Cough? Little cough. And fever? Yes. Chest pain, cough, and fever mostly we ask in patient inflammation of lining of lung, because if there is inflammation of the lining of lung, there is chest pain. Okay? And the most important cause of chest pain in respiratory system is pulmonary embolism. After that, I have to ask the patient about hemoptysis. Is there any blood in your sputum? And there is any blood in your sputum? No, there is not. Okay. And older patient, if there is carcinoma of the lungs, there mostly the most common presentation in that patient is hemoptysis. And in younger patient, it is more commonly seen in TB patient.
Hand and vital sign, nails, clubbing, and peripheral cyanosis, tar staining of fingers, tremors, flap. Check the patient vitals.
Now I have to check the patient hand for specific sign, and like peripheral cyanosis. Is there any tar staining? Is there any digital clubbing or not? I am checking digital clubbing, and digital clubbing most commonly seen in bronchiectasis and lung abscess. And tar staining, the most common cause of tar staining, we can see it in tobacco, like cigarette smoking, which is the most common cause. There is tobacco and there cigarette smoking, and peripheral cyanosis.
Face and neck, eyes, mouth, examination upper respiratory tract and neck.
Now I will see the patient face, mouth, and eye. Like in the mouth, we will see the pursed lips, okay, and central cyanosis in the tongue we can see. And if there is any use of accessory muscle or not, the use of accessory muscle and pursed lips indicate chronic obstructive pulmonary disease. If there is any central cyanosis, mostly we can see in the tongue, it will indicate the case of edema. So please show me your hand. Okay. So there is no.
Tracheal position. To locate the patient trachea, palpate with the fingertip between the stero muscle at the suprasternal notch. Inspection of the chest wall, shape, deformity, scar, rashes, and local lesions. Breathing pattern, deep, regularity, symmetry, accessory.
After going to palpation, percussion, auscultation, all these things, first I have to check some specific sign like leg edema. Is there any leg edema present or not? Which is most commonly seen in deep vein thrombosis. So first, Is there any pitting edema or not? Is there any thrombosis or not? The most common symptom of leg edema is deep vein thrombosis. Okay, and it will cause calpulmonale, and calpulmonale will lead to ascites. So there will be presence of ascites. There will be chest pain, and in some cases we can also see dull liver.
Palpitation. Any local abnormality seen in inspection, apex beat may be displaced, chest wall tenderness, expansion.
In inspection, mostly we see about the respiratory rate, shape of the chest. Is there any intercostal end-driving? Is there any pectus excavatum? In pectus excavatum, there is some kind of breastbone into the chest. Okay, and intercostal end-driving, intercostal muscle also can end. Intercostal end-driving most commonly seen in that patient when there is due to decreased air inside the chest, and the most common cause is that is airway obstruction. If there is airway obstruction, there will be less air in the chest, and that will lead to intercostal end-drain. So I will go toward inspection of the patient. Can I do inspection? I see here the most common site are intercostal end-drain here between the two. In the center of the chest, this is the most common side part, intercostal end-drain, and it can be seen in most common in decreased air in the chest. Okay. So there is no abnormality found on the chest.
Precautions. Ensure you cover all the lungs lobe and coastal space. Compare sides by alternating similar areas on right and left. Auscultation. Patient breathe with open mouth. Use the bell or diaphragm of the stethoscope. Compare right and left. Auscultate a large number of sides to ensure all lobes examined.
Mostly we do auscultation and respiration for stridor, wheezing, and all these things. It is added sound which is present in some type of cases like pneumonia, one of the most common cases. And we do for this, we use our stethoscope and check is there any added sound or not. Expire. I also from back side.
Fuel rub. Inflamed surface rubbing together, cracking noise, usually hear the both inspiration and expiration. Done.
So I perform my examination on my colleague Dr. Bangesh, and now I have to summarize my case. After complete history and physical examination, my patient name SanaUllah, age 22. I found no abnormality on Bangesh, so my patient Bangesh is completely normal. Thank you.